Hello, this is Dr. Bhomik. Welcome to the Pediatric Endocrine Lecture channel. Today I'm going to talk to you something is very important for general pediatrician and as well as the pediatric house staff, medical student and nurse practitioner. This is a very basic lecture, so I hope that this will be helpful for everybody that I have mentioned. Before I go and start talking about delayed puberty, I would like to go through the sequence of puberty, and I'll go through the progress from pre-puberty to puberty. So let's look at this slide, and you can see that before puberty the sex steroid level is low, and so is gonadotropins. And hypothalamic gonadostat is functional but restrained. Long time ago, in 60s, we used to say that hypothalamic gonadal axis is sleeping. They are absolutely non-functional. Then we know now that they are functional but restrained. And in pre-puberty, the hypothalamic gonadal axis is very sensitive or highly sensitive with the low sex steroid. So in the beginning of the puberty, the first thing that happens is the decreased sensitivity of hypothalamus to the negative feedback of sex steroid. Estrogen in case of female and testosterone in case of male. So decreased sensitivity of hypothalamus, and this is sometimes they call that hypothalamus become more greedy. And as a result of that, there is an enhanced secretion of GnRHs, gonadotropins, and this augmented secretion occurs in the fashion of pulsation, and most of the time in the beginning it is at night, and there is LH pulsation followed by FSH pulsation. And one thing has to be remembered, that hormonal changes occurs before the clinical findings or clinical sign of puberty. So as the puberty progresses, then we can see that changes of gonadotropin from low to high level. This is a very good diagram in my opinion, and this I have taken from a old pediatric endocrine textbook by Selna Kaplan. And as you can see that this is the tie diagram, just a tie, looks like this is gonad, this is pre-puberty, gonadal steroid is low and it is operative but very sensitive, and then FSH, LH, they are there but they are low. And then as the initiation, at the time of initiation of puberty, and there is an increased sensitivity, and slowly and gradually the tie is getting more broader and the gonad size is getting a little bit bigger, and this is at the initiation of puberty and this is at the completion of puberty. And as you can see that this is adult level, and broad tie diagram, FSH LH level is high and the gonad is bigger of adult size. So this tie diagram actually is a pretty good representation of what I have said so far. Okay, this slide is most important, and I would say that if you just remember this bullet statement or write it down, or whichever way you can capture those, I believe that you won't have to read too many of textbooks and so forth. So let's see that sign of puberty in girls. The breast budding is the first sign of puberty, and then pubic hair generally appears after breast budding, but in some cases there may be pubic hair and breast budding is occurring together at the same time, or maybe pubic hair in generally preceding the breast budding, but those are uncommon and those are aberration. So what you should remember for the purpose of exam and knowing, the breast budding is the first sign of puberty in girls, followed by the pubic hair. Although pubic hair usually starts a little late, but is completed by about 3 years, and the breast development, or what we call thelarchy, is usually complete within 4 years. But this is not the solid number, there is always some variation, but if you remember this will serve you very well for the purpose of your examination or understanding of this slide. And this is also very important. The menarche, that is the first menstrual period, usually occurs when the breast development at stage 4 tenor. That occurs about 60% of the cases, but there is always sometime it could be 5 years, sometime maybe 2 years. So plus minus is there, but usually it occurs around 10 or 4 breast development stage. And pubertal growth spurt also occurs before menarche. So in other words, the height velocity goes up or more just before starting the period. So you more or less can tell that if there is an increased growth spurt, that will be followed by menarche. That is a very good predictor. And for the purpose of your examination and remembering, is menarche usually occurs 2 years after thelarchy, but it could go as much as 4 years or even 5 years. So I just want to give a little example here. Suppose you have seen a patient, is 10 years old girl, and you just found that she has just breast budding, and the mother asks you, the doctor, when do you think that my daughter is going to have her menstrual period? So you just told her that it's around 12, just by using this formula, about 2 years. So you just say around 12. However, at the age of 13, if this mother calls you and tells you that, well, you told me that the menarche or the menstruation going to start around 12, but it is 13 and still it has not occurred. So what do you do at this situation? The first thing you should do, examine the patient. Make sure that the puberty has not been stagnated. What I mean is that the breast budding has progressed to stage 2, 3 and close to 4. If there is no progression, then that's concerning. But if there is any progression and continue, and just assure the family that everything is going in right direction, and sometime there may be delayed from 2 to 4 years. But you must examine, because we do know sometimes the patient like Turner syndrome, those who are mosaic, they may indeed have breast budding, but that's it, they don't progress any further. So physical examination is very important at that point before you tell the family. Now let's look at that. This is a slide which is one of the best representation of what I am about to tell about the girls' pubertal initiation and the development. So look at here. Here is the breast budding right here, and then stage 2. There is stage 1 is prepubertal, stage 2 stage 3, stage 4, and right here is the menarche. Right here is the menarche. Okay. And the pubic hair, as you can see, that it started a little bit late, right here, and also completed to the stage 5 just a little before the complete breast development. So this is a very good diagrammatic representation of what I have said so far. Now let's come to the boys. The physical changes that occurs the beginning of the puberty in boys start with testicular enlargement, and this is by far 100%. Testicular enlargement is the first sign of puberty in male. Sometimes people say pubic hair development, but they probably look at the pubic hair, but without examining the testicle, they always miss that. So in other words, first time of pubertal development, first sign of pubertal development in boys is testicular enlargement, almost 100%. And that followed by the other genital changes. Pubic hair appears after the genital changes, just the beginning of the enlargement of phallus. That's what I mean by the genital changes, at the beginning of the enlargement of phallus. And voice usually generally breaks about the same time when there is appearance of axillary hair, and that coincides in boys with the peak growth velocity. Peak growth velocity. And it is also believed when the axillary hair appears, when there is a peak growth velocity, and that actually probably time the spermatogenesis also begins spermatogenesis. The same type of diagram right here, and this is for the boys. As you can see that here is the testicular volume is around 4, and then here is the growth spurt, and this is adult testicular volume, and this around the age of 16 or 18 it might delay, and the genital changes also right here, and the pubic hair development is very nicely predicted here, depicted here, and this is in your slide. So if you look at that, this will be self-explanatory. Now let's look at this. Is a good diagram. This is called orchidometer, and as you can see that as I have indicated in my previous lecture also, that 4 is for puberty. 4 is the beginning of the puberty and the color changes, and usually around 10, when it's around 10, that's where you see the height, peak height increment. Around 12, 14, 15, that's about the voice breaks here, and you might also see spermatogenesis at this point. So 4 is the beginning of the puberty. Now let's talk about the delayed puberty. Definition of delayed puberty in girl is that there is no sexual development by 13 years of chronological age. Okay, 13 years of chronological age, can remember unlucky 13. In boys, if there is no sign of sexual development by the time they are 14 years of age, I mean chronological age. Now this is a number that does not mean that any of the changes that has not occurred, either breast budding or testicular enlargement, that does not mean they are abnormal. And that's where your bone age become more important. And so this is the definition, so you can work from there. But in general, what has been seen is that even in extreme cases, puberty is not delayed beyond the chronological age of 16 years for girl and 18 years in boys. However, I personally have seen some cases where they did not have period until they are 18 or no sign of puberty, and that you can see in many undernourished and under or developing country. The onset of puberty correlates with the bone maturation because hypothalamic pituitary gonadal axis is listen to the bone maturation. So bone age is most important is for endocrinologist. So etiology of the delayed puberty, the most common is constitutional delay of puberty, and that is very much coincide with the constitutional delay of growth and puberty. Family history is very important at that point. And other chronic disease, just remember that puberty period growth spurt can only occur if the patient is otherwise healthy. That means no systemic disease, nor like renal failure, cardiac disease, cystic fibrosis, asthma, inflammatory bowel disease, you name it. And the patient who has anorexia nervosa and also engage in severe form of exercise, I wouldn't say severe, that means continuous exercise beyond the physiological need and malnutrition, they all can delay the puberty. Since this is the endocrine lecture, I just have to tell you some of the endocrine cause. Hypothyroidism, delayed puberty. Hypothyroidism, delayed bone age. So therefore it makes sense that hypothyroidism will delay the puberty. So is the growth hormone deficiency. Growth hormone deficiency itself also causes the retardation of the bone age. As a result, you will see the puberty is delayed. The most common one is still, even today with the advance in control of the diabetes insulin pump, still poorly controlled diabetes do exist, and puberty can be delayed because of the poorly controlled diabetes. And the glucocorticoid excess, too much steroid production inside the body also may cause delayed puberty. So when you are as a primary care physician, pediatrician, or before you refer them to the specialty, these are few workup that might be revealing and very helpful. Obviously, I told you about the history, physical, height, weight, growth velocity. Among the screening tests, the first thing should be bone age. Then, obviously, blood count, make sure that patient is not anemic, set red to make sure you are not dealing with any chronic disease inside the body, and the chemistry profile, urine examination, and so forth. Endocrine obviously include the T4 TSAs, and you also measure FSAs, LAs, and that will help you to see whether gonadal axis has been activated. And for boys, you do testosterone level. For girls, estradiol level. IGF-1 and prolactin is also a very good test because high level of prolactin that can be seen in the prolactinoma also delayed the puberty. And karyotype. The karyotype is very important because many a times a girl like Turner syndrome, especially mosaic, they might present with delayed puberty. Have not seen the doctor at all, and just think because the girl is not going through puberty, especially for the mosaic one, that they might not have any very typical features of Turner syndrome. And For boys also, like a Klinefelter syndrome, they don't go through the puberty completely. They might need some help. But for girls, it is especially for the girls, karyotype is most important. But we do the karyotype in boys if we suspect that the delay is significant and concerning. Now let's talk about definition of primary hypogonadism. This is important for you to understand is that primary hypogonadism means the defect lies in the end organ, ovary or testicle. So as a result of that, you will have high FSH LAs. That means there is enough production of gonadotropin, but peripheral or testicle or ovary is not responding. So there will be low testosterone in boys and there will be low estradiol in girls. So high FSH, LH, low testosterone and estradiol is the hallmark of primary hypogonadism. Secondary hypogonadism, everything is low. Testosterone is low, estradiol is low in girls, and FSH, LH is also low. And in that situation, we do use GnRH, gonadotropin releasing hormone, to see whether there is any response to hypothalamus and pituitary hormone level after the stimulation. Clearly, this is where you should be sending the patient to the endocrinologist. As far as the management is concerned, management is most efficiently done by obtaining an endocrine consult, and that's all I am going to say about this, because this becomes a little more complicated than a general pediatrician or the pediatric resident, and they need to consult that. Thank you very much. My next lecture will be precocious puberty. So now that we have learned the delayed puberty, and next will be precocious puberty.